Thank you. So I think
بالمصري ولا
I'm doing ophthalmic trauma for last 40 years, and I'm happy I could hug Barbara, because I think whatever was in the mind, and I think thanks to our teachers Raja Jonovich and Farhan School, and here my master is here, Thanasis. So Thanasis is seeing. So I think the keynote address was fantastic, and she kept a I think this should have been in the morning, but anyhow, looks like at the end of the day, we want to go saying that every eye should be repaired. And I think whatever it is, I think I have one of the video where he's an 85-year-old man, didn't want to disturb his wife. He gets up in the dark, didn't put the light, but something sharp went in and out and came. He lost the eye. So I did 5 surgery, but he was 85 and he was ready. And after that last PVR, he said refused for further surgery. So patient, the doctors, relatives have to decide. So I have made this talk key factors and steps in improving trauma repair surgery to restore eyeball and vision. So if you don't operate a trauma patient, how will you yourself get experience? And that's what I learned from Raja Jonovich. For people who don't know him, he retired in '96. He was called the father of modern silicone oil vitreoretinal surgeon, and our Professor Bonnet used to tell he's siliconovish because she thought he's only injecting oil. But actually, he has written in his book that the maximum number of trauma surgery he was doing in those days in 80s in Rotterdam and then in Antwerp, I think is amazing. And that's what is the base for me to continue doing trauma repair. So we all know the definition and the term I introduced in the morning. Ocular trauma should be ophthalmic trauma because it can include lid, adnexa, the bones, everything. So it is a number one ophthalmic emergency. The leading cause of blindness, you saw millions are going blind with trauma as per WHO and the United Nations, irrespective of age, sex and geographical status, and 40% of monocular blindness. And it has been thanks to the speaker from Bangladesh who included this in the Vision 2020 in IAPB also as a statement that every individual should be eye should be examined, and efficient referral expected from the professional. So don't give up. Whoever is seeing a patient anywhere in the peripheral part of the whichever country you are in, thinking that the prognosis is bad, maybe worst, but even if there's no PL, please don't enucleate, don't eviscerate, refer to a senior colleague possible, wherever possible, but do the repair. And then every person should know about the importance of quick response to an ocular injury, and prophylactic measures is always better than management. So we have so many traumas happening: accidental, self-inflicted trauma which happened during COVID, occupational trauma, then physical trauma, chemical trauma, thermal trauma, radiation, miscellaneous, and you also have the war injuries now, and open globe injuries, closed globe injuries. And then so assessment is important. I think the whole day we had oculoplasty, we had the orbit, the cornea, retina, everything. So we also spoke about endophthalmitis, and then if you have a patient with the injury and endophthalmitis, and I think you have to act as an emergency, almost tackling like an ischemic heart disease. And these are the signs, and then the risk factors. So the main thing is that if you have a traumatic endophthalmitis, I think it can be multiple organisms. So you have to collect the vitreous aqueous specimens and causative organisms. So for that, you send for PCR culture and evaluate with the CT, MR, depending on the eye, as I said. And then you also, apart from the EVS study, the endophthalmic vitrectomy study, which says mostly post-operative endophthalmitis, we should here use systemic, periocular, and topical antibiotic prophylaxis, because the multi-organism will be a problem in this, and intravitreal antibiotic therapy. And then these are the various administration of the eye. Finally, vitrectomy is important, where you remove the most of the bolus of infection from within the eye. And then here, sometimes we use a long cannula because sometimes the choroid can be enlarged, and if you have a infusion in the suprachoroidal space, you have a problem. So here you have a pre-op photo with a traumatic endophthalmitis, and then this was designed by Dr. Frank Koch from Frankfurt. He called it Intrector, where he had a 23 gauge cutter with a sharp needle like thing. So you just go transconjunctival, transscleral. This was a fungal endophthalmitis, and we could see that material. So we used the microscope without the endoillumination with one port, and you have that 600 cuts per minute. I know it's a problem. You can use the contact lens and use the operating microscope and remove the material, and also simultaneously inject the drug. You can also use 27 gauge depending on the eye, and then intravitreal steroid is a controversy, but if you are sure there is no infection, then you can give. But in an endophthalmitis, don't give. Treat the eye, and then when the infection is over, then you can give the intravitreal steroid if required. And we saw the beautiful video by Barbara, so I hope I will also show. So I planned this temporary corrector process, and you can see this eye. You'll be seeing that it looks like this is again a flaring or ring. I used the corneal abscess was too much, and my anesthetist said, "Are you doing a internal evisceration?" I said, "No." You can see the phlegm-like material. There was a thick plastic thing on the surface of the iris, which I do the wound cleaning, and then I don't do the corneal surgery. I call my colleague, and then she does the corneal button. She came and told me, "You're wasting a cornea." I said, "No." You can imagine you're going to save an eye. Till the time the eye is not gone into, you can see like a thick phlegm in the back of the eye, and I'm using the Acart's corrector processes. You should do a airtight, watertight suturing. So I take a break when the corneal surgeon does this. So I have to make sure that this is airtight water, but you have to keep the, this was a 20 gauge, you can see, it's before 2000, I think it should be in the 95, I think, because I'm using the 20 gauge infusion line, which you'll be seeing now. So through the temporary corrector process, the whole thing is looking very, you will be able to see it. So can you play? Yeah, okay. So you can see I'm using a MVR blade and placing the 20 gauge infusion line, and you make sure that the infusion line is within the eye so that it's not in the suprachoroidal space, because it will be a disaster. And you can see before the 23, 25 gauge era, we were doing the 20 gauge and then make the other two ports also without any trocar, and you'll be seeing that you will be able to see that the vitreous X-rays are cleared, and it looks like that so you can see the infusion line, and then you clear this. It looks like that maybe the retina is so bad behind, but ultrasound said the retina was attached. So with that hope, and also keeping a suspicion of the retinal detachment, we work carefully, make sure the cutting rate is high and then suction is less, so that you slowly remove the exudate from the canine. And you will be seeing shortly, once we clear all the exudate from the vitreous cavity, you will be able to see the optic disc and the macula and the rest of the retina clearly, which is a really we'll be happy that you operated on this sort of patients. Otherwise, you would have gone in for panophthalmitis, and finally a nuclear evisceration should have been done. But we could give the intravitreal injection, do a keratoplasty. You will be seeing shortly after clearing all the muck, and you see that eye is clean, and you can see the optic disc and macula. Then you do the penetrating keratoplasty by the cornea surgeon, and then give the intravitreal injection also. So the idea is this sort of eyes you can save, and the patient can get vision. And I planned the same temporary corrector process for an eye with a corneal perforation, and unfortunately referred 3 weeks later. So I think any surgeon who is not doing trauma work, doesn't matter, but examine the patient, counsel the patient, and make sure somebody does the wound repair. If you are not well equipped mentally, physically, and operating room wise, send it to a person. Should be done as in hours or minutes, the primary repair, and refer to a tertiary care. And as I said, particularly when there's an endophthalmitis. You can see this eye, I planned open sky, not open sky, I planned a keratoprosthesis, but by the time the corneal surgeon removes the cornea like this, which is sutured, and when you remove, you see that I'm not able to place the temporary keratoprosthesis because there's a whole necrotic tissue over the iris, over the retina and choroid. I don't know what is what I'm removing. So this looks like a micro evisceration using the open sky vitrectomy using the cutter. But the only thing is, because the patient had not gone in for panophthalmitis, I took the chance and did clear all the debris of the eye. I don't know whether I'm removing the necrotic retina and choroid, maybe, but it was not. But it was everything looking brownish. But that means something. The whole thing is turbid because of the 3 weeks endophthalmitis. you can see the iris is swollen. Now I will clear the surface of the iris by using the forceps and scissors to clear all the debris from the antechamber and the angle as well as the iris, and then hope the eye will remain quiet after the PK. So you can see that a whitish material being removed, and behind this is the exudative material on the surface of the iris. So you need a patience, you need as Barbara said, it's a philosophy. If you are a vitreoretinal surgeon and you have decided to do ophthalmic trauma as your career, and that's what I'm doing. This is the 40th year I'm doing the eye injury repairs, and I'm not tired of repairing. Many eyes are no PL, but many eyes are only PL. Some are hand motion, some are 1 meter, and definitely when the vitreous hemorrhage with retina attached, you get 6.9 and 6.6. So this patient, you can see that he had a post-operative 30, the cornea was clear, and there is a possibility if you don't have a clear, regular, fresh cornea, you may use a preserved cornea, and maybe you have to do, if the eye is doing well, a therapeutic keratoplasty, an optical keratoplasty later. This was a therapeutic. You can see the pre-op, no PL to post-op, counting finger close to face. But I think the patient needed, after some time, the eye became, and this is again a 6-year-old male patient with a male boy, actually a firecracker injury. I'm trying to make a court case against the firecracker bursting in India, and there's going to be a lot of this business. People will come against me, but I don't care. But this is my dedication to. So this you can see the firecracker injury had a vitreous exudates and a traumatic retinal detachment, and I'm now clearing the. And it took it's almost 3 to 4 hour surgery, and you can see I'm clearing and also clearing the debris from the anterior part going posteriorly. I'm fast forwarding because I can see that most of the exudates are cleared, and I use the PFCL and make sure the retina is attached, and then peripheral subretinal fluid is drained, and use a PFCL oil exchange. Again, thanks to the learnings me, Cesare Forlini, and our Tenasis were attending all the workshops by Dr. Jovanovic in Antwerp and Rotterdam before that. So the idea is not to leave any eye, and he had the worst cases coming, of course, late, and you can see I'm using the multiple entry port and also using the AC maintainer, thanks to our friend Michael Blumenthal, who introduced that for the anterior segment surgery, and then he gives the intravitreal antibiotic. So the prognosis remains dismal in spite of recent advances. As Barbara said, if you don't do that repair immediately and attach the retina as much as possible, make the media clear, then sometime later you can't do anything. I mean, if he's one-eyed and in that one eye he has an injury, and then if you are able to reattach the retina, there's a lot of work going on in artificial retina. I know 3 or maybe 10 companies have come and gone. Yesterday I saw, without a trial, Australia has announced that suprachoroidal artificial retina is being there. So this is again a traumatic RD with the this is what I said, 76-year-old male who got up in the night and went to the toilet without putting the light on and had an injury. So I'm doing this was the first surgery was done, and while I was doing vitrectomy, the expulsive happened, and then I closed the eye, and then you can see that time I used the Denziron, and then there was a subretinal Denziron, you can see, which is gone in the subretinal space. There's a large temporal tear, macular hole, and PVR. So don't give up, and you can see I'm now using a long needle to remove the subretinal oil. Looks like a pearl inside the subretinal space. Anyhow, I have multiple videos. So I thought I had 14 minutes. It's over. Right? Okay. So this is and then you can see I'm removing the PVR by using the retinal brush, and I'm actually going through the macular hole, which inexperienced surgeon should not do. But you have to be careful not to touch the end of the eye. This one, and you can see the oil is injected, and then this was the second surgery, and this is again another surgery with a corneal wound repair done, and this was all done on the same day of injury, and then removing the pellet from within the vitreous hemorrhage, and behind that was the subretinal hemorrhage and retinal detachment. We all tackled it, and then this is the patient with the PVR with the total detachment with a large retinal tear temporarily with the macular hole. I did a laser around the macular hole also, but in spite of that, the patient developed recurrent PVR, and I did 2 more surgery. And this was another patient post-cataract, had an injury, and then you can see cataract remnant material. The lens was not put, so I cleared the anterior segment using the anterior approach, and then using the AC maintainer and cutter through the same wound. We are removing the vitreous hemorrhage and also using the PFCL to do the subretinal hemorrhage.
Dr. Natarajan, we
Yeah.
can conclude, please.
Yeah, so okay, I think can I go to the next slide and I think conclude I think. Yeah. So this was the post-operative picture with optic disc pallor, but the vision was 624. This is another eye with a corneal injury with a traumatic cataract. CT scan showing the pellet has gone through and through. So don't give up. You can operate, and then patient had a corneal astigmatism which can be corrected following silicone removal. Thank you very much.